Okay, thank you everybody for joining us over lunch today. We're going to just spend hopefully about 20 minutes talking about this new device called the TOPS device, TOPS system. It's essentially an artificial facet replacement, much like we would do a hip, shoulder, knee replacement. We can now replace the facet joints in the spine. So just quickly myself, I'm here in Harrisburg, Pennsylvania. I'm general orthopedic spine trained. Of course, I do non-operative and operative care for all of these different orthopedic and spine conditions that I treat. And as such, I have done non-fusion surgery, fusion surgery, instrumentation. I have a strong interest in motion preservation as well in the neck and the lumbar spine. Disc replacement in the cervical spine has been shown recently to really be working well in patients long term. Disc replacement in the lumbar spine is still a little bit of a question about how that's going to work long term. There's lots of technical difficulties with that. Approach surgeons to open up the anterior aspect of the spine to get to the lumbar disc. So cervical disc replacement currently good. Lumbar disc replacement, big question mark. So what can we do to think about motion preservation in the lumbar spine? And that's where the TOPS device comes in. So the TOPS device, we just concluded our 5-year IDE FDA-approved study on this device. The device actually has been around for 18 years globally in practice and in clinical development. But here in the United States, we did complete an FDA study, which I was part of, and it is an alternative for grade 1 degenerative spondylolisthesis in adults who have lumbar spinal stenosis and radiculopathy. The data from the IDE, I'm going to present some of that today. It was a prospective randomized blinded study versus a single level spine fusion. And we actually got FDA breakthrough designation for the device in 2020, and it's now available commercially. So when we talk about the joints of the spine, they're very similar to joints elsewhere in your body. They're the facet joints. The facet joints have, with pain management doctors, they're very familiar with facet disease causing back pain and symptoms. And what we're looking at here is, the facet disease is causing the spinal stenosis. It's not going through the disc, which is more traditional. So when we talk about the motion of the spine, of course, we have the disc, which is responsible for the axial loading, and the facet joints, which resist shear and motion. And although the disc carries most of the load, the facet joints are very important for translation, rotation, flex-X, and lateral bending. And they are really the determinant in motion of the spine. And again, when these facet joints become arthritic, traditionally we would think that, the disc is arthritic, you get increased motion at that segment, you get facet hypertrophy, ligamentum hypertrophy, spinal stenosis, and radiculopathy. But in some patients, the disc, for whatever reason, is still very good and viable, but yet they have this severe facet arthrosis. So that's the patient that we're really looking for in this procedure and in this operation. The patients that we can help are patients who have lumbar spinal stenosis, they have a grade 1 degenerative listhesis, they have severe facet arthrosis, but they have a good disc. And again, that's not every patient we'll see, but in the right patient, the TOPS device can help. Traditionally, what would our surgical options be? Well, you can do a decompression. You can do a decompression and fusion. Now our third option is a decompression and motion-preserving arthroplasty of the facets. So historically, the ODI at 2 years in patients who have just decompression alone versus decompression and fusion in a grade 1 listhesis was looked at. Some of this data is over 30 years old. And basically in the green is decompression and in the blue is fusion. And if you look at these 3 landmark studies, it's not really conclusive on what's better, just decompression or just fusion, which is why, is there a better option? Is there a better way to treat these patients who have this degenerative spondylolisthesis? And that's where the TOPS device and facet arthroplasty are a reasonable and viable option in the right patient. So when we talk about the right patient and the right surgery, decompression alone is very good at alleviating neurologic compression. Fusion is very good at alleviating neurologic compression and motion. But is there anything that can do all three? Is there anything that can alleviate neurologic compression, still allow stability to the spine, and still allow mobility? And again, decompression alone and lumbar fusion fail in one or two of those arms. So what we're talking about here is the device you're looking at there, which is the Facet arthroplasty device called the TOPS device. And if you notice there, it allows normal range of motion of the facet joint, lateral bending, flexion, extension, and rotation. And again, you'll see that the pedicle screws are going into the pedicles at, we'll call this L4 and L5, and then the device connects through the pedicle screws, but allows motion through the bearing surface of the device. When we talk about the surgery, the most important part of the operation, obviously, is the decompression. So we do complete facetectomies, totally removing the facet joint. And then the mobile polyethylene bearing is what's going to allow motion, but with constraint. That's very important because there's been other devices where they have pedicle screws in and then they put like mobile rods and things in. Those devices will allow motion, but they don't really restrict. They don't really support the appropriate function of the facet, and they don't have enough constraint. So although there's motion, it's abnormal motion or excessive motion, whereas the device itself will provide more normal motion compared to the normal facet joint. And here we're just looking at a patient in surgery. The patient's indication is flexion, extension, and stability of the grade 1 listhesis with a good disc. So this is the most important part, is the decompression. Now we're going to place pedicle screws like we would normally. The screws here technically have to go in a little bit more accurately than, say, a normal fusion would. And that's the forces of the device are distributed equally over all 4 pedicle screws. But there's an intraoperative pendulum that helps you make sure the trajectory is appropriate. Then you trial and you size the device. The device comes in a couple of different sizes of the implant itself, and then it has several different angles on the upper arms, 3 different options depending on patient anatomy. Then the device is assembled on the back table. The final device is then implanted. It's then attached to the pedicle screws with normal screw caps. Again, instead of putting rods in here, we're putting the device in. We check the device on X-ray before deploying the device. And then this is the post-operative X-rays where the device is anterior and posterior. And then we usually get forward flexion and side bending X-rays demonstrating the device is moving with constraint. Again, it's not going to allow too much forward flexion, too much side bending or rotation, but very much identical to the normal facet joint. And this slide here shows the MRI of that patient who had surgery. They have a very disc at 4-5. The disc height is excellent. They have severe spinal stenosis. Those are on the upper 2 preoperative images. Post-operatively, on the bottom 2, 24-month MRI per protocol for the study. Excellent decompression. The listhesis has been reduced, which isn't a main part of the procedure, but with the device you find that it really does stabilize the spine, which is the key here. Back pain, right, left leg pain, and ODI are all improved significantly with the decompression and with the TOPS procedure and device compared to preoperatively. And again, these are the X-rays that we get. You can see the device allows motion. We often, for fusion, get these same X-rays trying to confirm that the segment is not moving, to confirm you don't have pseudoarthrosis. But in this device, with the TOPS device, we want to see the motion on flexion, extension, and side bending. It's a very, again, normal type of motion through the facet joint, through that healthy disc. And you can see that on these dynamic X-rays. So what did the actual study look like? Again, it was a grade 1 degenerative listhesis with spinal stenosis in adults who were non-obese, who primarily had leg pain more than back pain. That was the criteria. It was only 1 level. And again, the disc was important to have a good disc height greater than 4 millimeters. There was some constraints on the study, which are no longer, such as a previous fusion, so say at 5.1, and the patient had a grade 1 listhesis at 4.5 with a good disc. That patient wasn't included in the study, but those patients are excellent patients for the device currently. I've actually done that procedure where I've added the device above a fusion. So, and we see these things commonly. And again, it's not going to be, the patient who has multi-level severe degenerative disc disease and scoliosis, or even a severe degenerative spondylolisthesis with a poor disc. It's that patient that has severe facet arthrosis, spinal stenosis, claudication, radiculopathy, and for some reason a healthy disc. That you just feel bad having to fuse that and putting like a 14 or 60 millimeter cage in there, taking out all that good disc. We can use that disc and preserve that motion in the right patient. So how did they do? Well, here's some data from the 24 months, and the TOPS device is in the blue compared to the fusion device, which is in the red. And the criteria that was looked at to achieve clinical success was no revision surgeries or additional epidurals postoperatively, significant reduction of the ODI greater than 15 points, no new or worsening neurologic deficits, and no major device adverse effects or failures. And you can see that the TOPS outperformed fusion through all the criteria that were looked at, all the clinical criteria that were looked at through the first 24 months. Now, if we add fusion to this, and here's the overall composite. So when you look at that data differently, this is what it looks like. When you add all of those together and dissect the data out, the overall composite clinical success was 78% for TOPS, 53% for fusion, which is a significant advantage. That's a significant number for improvement for TOPS compared to fusion. So then, obviously, if you add fusion or pseudoarthrosis, non-fusion into the mix, you can see that the TOPS obviously really outperforms because we're not waiting for fusion. When you add fusion, the success rate goes from the 58 down to 24%. I just had a patient earlier today who would have been a great candidate for the TOPS study, but her BMI was over 40. She's 6 months from her fusion surgery, which was not included in the study. But she has back pain. I've done 2 CAT scans. I'm not sure if she has pseudoarthrosis. I can't explain the pain she has. And we just don't see that with the TOPS device because pseudoarthrosis is not an issue, obviously, because there's no fusion involved. And we're finding that these patients are doing better than fusion, and they're also doing better quicker, and they maintain that improvement over time. And again, to look at the ODI and break down each one of these measurements a little bit more, the TOPS here versus the fusion preoperatively had the same ODI, and you can see the significant reduction in the ODI at each week, at each interval from 6 weeks to 2 years. And at each interval, both groups improved. And it's important to note that fusion is still a very good option, but TOPS is better at each interval here. And again, TOPS patients had better improvement at an earlier stage and maintain that over time. Same thing with VAS back pain. This is the hardest thing we do as spine surgeons is treat back pain. And I always tell patients, I can't treat back pain, but I can fix radiculopathy and neurogenic claudication and these other things. But even back pain improved significantly with both fusion and TOPS. But as you can see here, much more significantly with TOPS device, and TOPS that improved and maintained that improvement over time where fusion did not. And again, here's leg pain. Again, the decompression is the key, both in fusion and in TOPS. But again, TOPS outperforms fusion at every interval. And then if we look at motion, this is what we're hoping to see. In fusion, you don't want to see motion. In TOPS, we're seeing motion. Preoperative to postoperative, you can see that, and this is the angular motion, the side bending is very much the same postoperatively with TOPS as it is preoperatively. If you go to flexion extension, same thing. The flexion extension with device mirrors a normal, lumbar spine. When you go to translation, same thing. The TOPS device obviously outperforms fusion, which it's supposed to, but the key here is that it kind of maintains normal physiologic motion when you compare it to pre-op versus post-op. Then when you talk about the device and the study, were there any sort of significant complications? And if you look here, TOPS in blue, fusion in gray, the overall complication rate was 5% for TOPS and 8.5% for fusion. And so basically, this tells us that the procedures are fairly equivalent. There's not a higher risk of having complications by someone doing a TOPS procedure compared to fusion. Additionally, I train doctors in how to do this procedure. I've been training doctors for 6 years. It's not an overall complicated thing to do a TOPS device compared to fusion. The instrumentation is simple to use. It's easy to use. If there is any sort of problems or complications during surgery, you just simply convert it to a fusion. Knock on wood, say my prayers, I've never had to do that. And overall, the instrumentation is easy to use for surgeons who are comfortable with pedicle screw instrumentation, and also for the staff in the OR. Again, one tray, all the screws and things are sterile packed. So there's not a huge tray of screws and things that need to go through FPD and been washed multiple times. Where is TOPS now? The first generation paper has 11-year follow-up. There's 2 published papers in a European study that was a 5-year study as well. There's been several publications from our IDA study here in the States, some of which have been shown with economic data that shows that TOPS outperforms fusion. And there's one society publication discussing the work RVUs comparative to TLIF. Now, I'm going to kind of skip these next couple slides. It kind of goes over reimbursement. If any surgeons are out there that are more interested in kind of the reimbursement and things for the facility and for themselves. The bottom line is, the Medicare will pay up to $11,000 for the device. So it's not like your hospital is going to lose money on this device, which is kind of the key here. But if you're interested in the device, you're interested in doing the procedure, there's some financial information to tell you that, the hospital and you're not going to lose money by doing this device compared to fusion. So again, it's not for every patient. They have to have a good disc, a grade 1 listhesis, 4-millimeter disc height, no motic changes on their MRI. Just like any patient we operate on, we want leg pain more than back pain. Active, healthy patients, 40 to 70, even up to 80. I actually just booked a case for a gentleman who's I think he's 80 or 81, has excellent bone quality. He's got a degenerative grade 1 listhesis with amazingly a great disc. I think he'll do great very quickly with the TOPS. He's not going to have to spend, months in a brace. He'll get back to his activity very quickly. I still try to not operate on morbidly obese. That was one of the contraindications in the study. Bone quality is important. Females in their 50s or above get a DEXA scan to make sure they don't have any sort of osteoporosis or osteopenia that would potentially cause any sort of screw cutouts with any sort of device, whether you're doing a fusion or TOPS, but a little bit more essential in the TOPS. And again, at 24 months, it's the FDA has determined that it is superior to fusion. It does maintain the motion, so it's really the first and only facet motion-preserving device out there, and clinically effective solution for the correct patient with the grade 1 listhesis and severe spinal stenosis with claudication radiculopathy. So that's all the information I wanted to present to all of you. If anybody has any questions, I've left some time for us to get through questions, if I can help out in any way. I've done several dozens of these now. In the study, I did the first and the last TOPS and the fusions. I've done some in my clinical practice since the study ended. I put TOPS above fusions. So I have experience, and it really is a nice device to put in your toolbox for when you need it for that patient who comes in who's the perfect indication. Any questions? And I know from a pain management standpoint, patients who have facet arthrosis who undergo facet injections and medial branch blocks and radiofrequency ablations, if those patients, don't do well long-term, if their primary problem is a one-level facet arthropathy, and it is between L2 and L5, and they have a little bit of a listhesis and they have a good disc, those are patients that we can also help with this device should they have failed all other conservative measures, compared to a fusion, which a lot of patients feel for a fusion because of adjacent segmental degeneration, which we think and postulate that is going to be much better with the TOPS device, and we'll have to see what the long-term data shows. But the midterm data is promising that the TOPS device is going to preserve motion and preserve the levels above and below. So there are patients out there looking for motion preservation devices, and again, the TOPS is the best facet arthroplasty, only facet arthroplasty option out there. And in my region currently, not doing a lot of lumbar arthroplasty, lumbar disc replacements, but facet arthroplasty is an excellent motion preservation option. Any questions at all? The other thing that's nice about TOPS compared to fusion, the recovery is the same. So they're in the hospital the same amount of time. The blood loss is the same. The big thing is in a motion preservation like this, we can offer them anti-inflammatory medications immediately post-operatively. In fusions, they can't take NSAIDs. NSAIDs have been shown to reduce bone fusion. So no patient with a fusion ever gets any sort of NSAID, any COX-2s, Toradol, none of those things, because of the potential risk of pseudoarthrosis or non-union from the fusion. But with the TOPS device, obviously you're not waiting for fusion. So that's another huge benefit to this, is it gives you a whole large category of medications you can use in the immediate post-operative period for TOPS procedures that you can't for fusion. Additionally, is the immobilization. The patients don't have to wear a back brace after TOPS. They can, be more active more quickly compared to fusion, where a lot of times we'll put them in braces for 2-3 months just to try to restrict them from doing too much motion before that fusion starts to take place. The radiographs we demonstrated earlier are very simple and easy to review in your office, compared to sometimes when you're looking at a fusion, you're not sure if the fusion is occurring or not. Like I was describing that earlier patient, I've had to get 2 separate CAT scans just to see if I can find out why her back is still hurting. Did she have a fusion or not? So post-operative recovery is a lot quicker for those reasons. We have more options medication-wise for TOPS patients. And the x-rays are very simple and easy to interpret in your office when you're in just routine fashion.
Thanks, Steve. We appreciate the information. And if anybody has any other questions later in the week or in subsequent weeks going forward, you can drop us an email and Steve will be able to answer your questions.
Yeah, I'm very happy to, answer any questions anybody has. Again, my name is Stephen DeLuca. I work at Orthopedic Institute of Pennsylvania. My email is very simple, sdeluca@oip.com. You can always reach me through the Premia Spine webpage and Ron, and whatever I can do to help anybody. I'm trying to get the word out on this procedure. I have incredible success with this procedure in my practice. Personally, knock on wood, I've not had any patient have to have any sort of conversion to fusion or revision procedures. My results have been very consistent with the study, early satisfaction that maintain over a long period of time. I've really been very impressed what this device can do and what it does do for my patients. And I've had, it's been a really great option for me to add to my toolbox for the right patient. And I think we all see these types of patients. And unfortunately, I think we're still fusing a lot of these patients who would really benefit from a facet arthroplasty device like the TOPS.
Great. Thanks, Steve.
All right. Thanks, everybody. Have a great rest of your day. And please reach out if I can help you out in any way.